Lõpetuseks ja võib-olla uue sellise mõtteainese veel siia lisamiseks me oleme kutsunud Soomes siia Liisa-Maria Voipio-Pulkki, kes on Soome tervishoiupoliitikas ja süsteemis, ütleme, et samal positsioonil nagu Iivi Normet on meie süsteemis ja tal on endal ka nii arsti, teadustegeva arsti kui siis ka ametniku kogemus ja ministeerium seal seda nii-öelda valdkondlikku või sektoriaalset teadus-arenduspoliitikat on juba mõnda aega teinud, nii et see kogemus võib-olla selles vallas alustavale Sotsiaalministeeriumile, aga ka teistel osalistel on asjakohane ära kuulata ja väikse remargina lihtsalt, et eelmisel aastal siis valiti Liisa-Maria ka kõige mõjukamaks tervishoidu kujundanud aasta jooksul inimeseks siis Soome mediuudiste nii-öelda poolt, kes 14 aastat järjest on selliseid tunnustusi jaganud. The floor is yours.
Okay, thank you. I was wondering if I should use English or Finnish, but I've learned my lesson that it's not correct to expect people to know Finnish. So, since I don't know Estonian, and that's why I'm using English in my presentation. Some of my slides are in Finnish. I hope it doesn't harm you too much. Most of you probably also can get the idea. But that also reflects that some of the issues that I'm going to discuss are so brand new that we haven't even had the time to prepare proper slides in English. But I made the choice to share those ideas with you anyhow after I got some instructions last night about the purpose of this prestigious event. But Madam Chair, Ivi, colleagues, thank you very much for the invitation to come to this event. I'm very honored by the invitation, and I feel that I better tell a little bit about my background here in the beginning so that you can easily judge if I'm right or wrong. I'm speaking here as the Chief Medical Officer of Finland, and it happens to be so that in my agenda, the research and development and innovation issues happen to be quite prominent right now. There are many reasons to this. One of that is perhaps that I came to the ministry about 5 years ago after having worked a few years for the local and regional authorities in Finland, but before that I was working in academic medicine and clinical medicine for about 25 years. I'm an internist, a cardiologist, and I have done quite a lot of translational research also in my past life. But let's go back to the topic of this presentation. The Finnish healthcare system is notorious for being fragmented, there being a firewall of public power between the state and the municipalities, and since research has been the task of the state and healthcare and social care in the autonomous hands of the municipalities by the Constitution. So there has been, by definition, a barrier between the research world, the academic world, and then the health and social care world. And I realized only now, when I was preparing for this talk, that actually in this picture, where we show the present state of affairs in the Finnish health care system, there is a teeny tiny hint that there has been an attempt to cross this barrier for the last 20 years or so. And that has been the earmarked money that has come from the state through the hands of the Ministry of Social Affairs and Health to reimburse the education that is given to healthcare professionals in the healthcare system, and also to support clinical and, to a certain degree, systems research being pursued within the healthcare system, because the patients are there, the data is there. And that is actually shown here as project funding, as specialized funding. Now, this comes from the state budget, decided by the parliament every year. But the total amount of the money is up to the Ministry of Finance. And so this money that goes down to the clinical research has been actually reduced dramatically to balance the overall state budget, even if it's not that big amount of money. It has come down from almost 60 million euros per year to something like 20 plus. And since this was the big booster of research being pursued in the healthcare system in the 80s and 90s, and I'm a living example of that, this has created a whole lot of criticism and is one of the most popular topics among the members of parliament when the state budget is being discussed. And every year they add a few symbolic millions of euros as a Christmas present to the healthcare system. But this is not sustainable, and so we have to take a few steps forward. So the steps forward are mostly affecting the health and social care system, and some of you might be aware that there is a major reform coming to Finland. We hope the parliament will pass the act in the next few weeks, just before the next parliamentary elections. And this is such an important reform in Finland that all the major parties, be they in the government or in the opposition, actually want to get this thing done. So we are pretty optimistic. The next government then has to scrap the multi-channel funding. I'm not going to touch these in detail, but as part of the multi-channel funding, also the funding of the research and development and innovation functions among the health and social care system will be addressed. But there is no news about that yet. One of the major infrastructures that supports both care provision, leadership and governance, and serves as a substance and tool for research is ICT. So this is a special part of my presentation. It comes in the end, although I know that e-health is separately being addressed by your processes. So why should R&D and innovation be in the interest of the healthcare organization? Sorry for the printing error. By organization, I mean here the state and the municipalities' public power that is responsible for the health of the population, as it is being written in the Constitution. Why should be in the interest? This is the major driver. What are the drivers? We cannot continue the way that we have worked up to now. The main reason is that there is a dramatic demographic change, and we have to adapt to that. And at the same time, this growing population, elderly population, that turns the relationship of those who support the system versus those who are dependent on the system upside down. Those people who depend on the system have also increasing expectations towards the service. They think that they have paid taxes all their life long, and since this is a tax-based system, so the pressure for demand to the care organizations and providers is also quite high. And unless we can meet this demand with good quality, flexible, modern services, those who can afford it walk away from the system. They buy their services from the private sector, which is existing in Finland, and then they lose their interest to support the public system through their tax monies. So this is actually the key issue of the future of the health and social care sustainability and social cohesion in the country. The major demographic change also brings a major change to the health and social care structure, the network. Most of our people are not in institutions anymore. They live in their homes. They live relatively normal, healthy life up to the age of 80, 85. After that, we know that above age 85, most of these people are dependent on other people's help and health and social care in their everyday life. So most of our services actually now are being operationalized not in institutions, not in hospitals, not in older people's homes, but in their private own homes or institutions that resemble home-like living circumstances. And at the same time, so we have this breakdown of the traditional division between primary care, specialized care, and home care. There are many reasons, and I'm not going to touch them in detail. There are legal reasons why we put together everything. There are funding and financing reasons, but there are also reasons that have to do with the paradigm change of care provision per se from inside of the health and medical care. And the patients, the citizens, they are not happy by being that passive recipients of care anymore. But they want to be more active, they want to make decisions themselves. Just wait when people of my age come to that age that we all need services. Our attitudes are going to be completely different compared with those who now are our main customers. And at the same time, if you see the blue health gain circle, those who fund the system, they want to know what they get with their money. What is the return of interest? And we have the responsibility to show the additional value, the health gain, from whatever we put into the system. And health is not an issue of health care. It is everywhere. It is now everywhere. And it is global, and it has so much to do with what's going on in life and society in other fields and sectors than just health and social issues. And I'm not going to touch this in more detail, but I'm going to mention here that it is just a question of time when people want to provide also information that is relevant to their health and have it as an input to our system. We are talking about big data, open data sources, the electronic fingerprints that we are all leaving around us all the time. And there is plenty of information that is useful for us and that people want us to make use of. The problem is that our system today is not at all prepared to receive it. Not legally, and it's not prepared to manage that type of data and make use of it. So this is one of the horizon scanning issues here. When we are talking about the more individualized demands, the traditional way of thinking is personalized medicine in terms of personalized care in severe life-threatening diseases, above all cancer. And I'm pretty sure that Professor Palotier is going to describe this type of attitudes in more detail in the future. I'm just briefly mentioning here that naturally, because this is the cutting edge field of medical research in the sense of personalized medicine, the National Cancer Center plan in Finland is one of the spearhead projects of our health strategy for the time being, because we cannot afford this type of activities being undertaken separately in different hospitals according to different protocols. It won't work, we cannot afford it. Talking about research and development and innovation in the healthcare, I also included here a slide about the attitudes of the big pharma when they judge our ability to cooperate with them in the more traditional sense of research cooperation. The interesting thing is that although the state has given money to the healthcare system to be used to let clinicians work in research, support their timeshare models, support infrastructures, Since the amount of that money has gone down at the same time, the lean process thinking has increased and the demands for performance in the healthcare system have increased, the outcome is that the clinicians find it more and more difficult to participate in research as part of their everyday life. And so the representatives of the big pharma today in Finland judge lack of time of the clinicians as the most important obstacle. And this is a pity, because we used to have that system. Then we somehow lost it. And I'm not talking just about pharmaceutical research, but I'm talking about research in a general sense. Within the healthcare system, it's an ebb and flow. Right now we have to reoccupy for example, the labor unions and so on, so that they will be more positive towards timeshare models and so on. But what is interesting here is the lowest bar, that we still have a very positive population. Our patients and our inhabitants are very willing to participate in research, and we should capitalize on that. So there were a few aspects of how research has been part of the healthcare system in Finland for the past 20 years or so. But there are now new drivers and new aspects of this discussion. The society and the political decision makers have viewed healthcare mostly as an expenditure for the last years. Now, in the times of financial austerity, there are two new ways of thinking that actually create a request for new data, new information. One is that, okay, has the health and capacity to act of the population something to do with our ability to recover economically? Of course it has. A healthy population is a major factor in economic life. Second, could it be that since healthcare is such a big enterprise, an industry, could we actually not just put money into it, but could we actually create something which is worth perhaps importing from our system, be they then results of traditional clinical research, translational research, systems research, new concepts, perhaps e-health concepts. This is not going to be a new Nokia, but this is actually something that brought together recently the three ministries, this new thinking that could healthcare actually be part of the growth engine, brought together the ministries of social affairs and health, ministries of education and science, and also ministries of economy and industry, which is unheard of in Finland. This is the first time that actually four ministers from three ministries signed a common document. And it was a major effort also from our ministry, which is traditionally known for health in all policies type public health emphasis. And it took some time, even for our civil servants, to accept that talking to the industry, talking to the academy, thinking about research is not contradicting the traditional health in all policies thinking. It's actually a new aspect added to that. And I was informed that Mr. Mikko Alkio has been describing the origins of this new strategy to you, so I'm not going to describe it in detail, also taking into account that I'm competing with a lunch, that Finland's goal as a country is to be an internationally renowned forerunner. You can replace Finland by Estonia here in health sector research and innovative activities. But the bottom line is that while this all should benefit people's health and welfare and capacity to act, it doesn't say healthcare or disease management. It says people's health and welfare. and capacity to act. I have to say that I had to read through the draft document very, very carefully from the population health and also ethical point of view, so that it could be palatable also to our ministry. So you have to be careful. There are different paradigms. These different ministries have different paradigms, but it's not impossible to find a common end pathway. So here is just the goals written a little bit more on the operational level. I'm stopping here, I'm not reading them through, stopping here for a few seconds. But I was asked to tell you something about where we are right now. As always, there's enthusiasm in the beginning, oh gee, this is great. And then we start to realize what the obstacles are in real life, beginning with the legislation. And you know very well that it takes 2-3 years to change the legislation, and it's a long time for the industry. So we have to have some low-hanging fruits and some immediate demonstration projects that show that actually this principle of bringing together sea-load paradigms, sea-load meritocracies is actually worth taking forward, that it really creates something new. From the academic point of view, if you strictly looked at medical faculties and how they are being credited, the fact is that by now, by the impact factor of their publications. And that's fine, no questions asked. But in the modern era, in this world, it's not sufficient. And in the long run, money will be short, unless you show that the impact factors actually will bring some added value to the population. So here are some of the practical sectors or segments of action that we have to undertake. Since the 3 ministries have their different rights and responsibilities, they have to act in a concerted manner. And for the time being, right now, it is our challenge to somehow govern what is going on in the 3 ministries, because we don't have one single government yet in Finland. All these ministries still have their own decision-making processes, their own networks, and so it takes time to put them together, act them together. From our point of view, it is also important to get the university hospitals and the university hospitals to act in a concerted manner. What I just said about the fragmented nature of the state government is applicable to the municipal health system. So now that we in Finland plan to have only 5 care organizations, and they are centered around the university hospital cities, it is important, if we want to have a national strategy, to make the 5 universities with medical faculties and health science faculties, technology faculties, and the university hospital campuses talk to each other, both across the university hospital barrier and in between. And here comes the interesting question. The honeymoon is over. Now the tough questions are being made. Who is going to profile this way and that? How are we going to share the burden? Can we cooperate? How to manage competition at the same time? So very practical questions and have to be tackled title by title. And I have an encouraging example, and that is the National Cancer Center concept. We were able to get documents from the 5 university hospitals about their special fields of interest, where they would like to do something on the national level. Not just Helsinki, which always thinks they are the best. But there is sometimes the best expertise in the country in some other center, and we have to find them out and make them cooperate, and not to do duplicate work. The duplication and fragmentation is also true for the funders. Actually, the research funding system in Finland is extremely fragmented. And one of the achievements of the new strategy was that one of our big funders, Tekes, actually took the time and put everything on a single PowerPoint picture, which didn't exist before this exercise. And I tell you an anecdote. This began on an airport where the CEOs of, I guess, 4 of the 6 major funders happened to be at the same time, and the flight was delayed. So they took a cup of coffee and started discussing the new health innovation strategy and its relevance to each one of them and their funding decisions. And it is an entirely informal decision that they are not going to fund duplicate work. This has to be structured and formalized at some point, but this is how it is for the time being. And since they are also independent actors, our challenge as ministries is to try to somehow have a whole picture and govern it where we want it to go. And here is a detail which I want to tell you about. This is a strategic research fund in the left-hand corner, lower left-hand corner. That is the Academy of Finland. Money was taken by a decision of the government away from the major funders, including the universities and THL, and given to the hands of a new board in the Academy of Finland. It's about 70 million euros per year right now, and they have the obligation to, according to scientific academic criteria, select major projects, but the titles come from the government. And they are supposed to serve decision-making and tackling the major societal problems that we are facing right now. So this is an expression of the gain request that the funders and financiers right now have. Another, perhaps the best example of the outcomes of the health research and innovation strategy is the support that the state now gives to the biobanks in Finland. And they are actually organized more or less formally to make the BBMRI.fi consortium. Actually, they have a meeting right now in Helsinki. I got to report that it's going better because we just saw the breakdown of the honeymoon season here, so that there was some competition between those who are now more advanced versus those who are just entering the business. But this is actually based on a new biobank law and is part of the ERIC agreements that the state of Finland has made with the European Commission. And we have great expectations that this concerted national action will actually be very fruitful. Another sort of spin-off of the health strategy is the genomic medicine strategy, now being written together actually by the ministry but supported by Sitra, which is an independent funder. At this point I have to say, has this really been a concerted action? We call it the National Health and Innovation Growth Strategy. No. It is actually a platform that right now brings together initiatives that have already been there, or been there in the air. But now they all have this sort of this label that they are consistent, or they are in line with the National Health Growth Strategy. But I'm looking forward to the time when we can say that we actually are better organized, that we have a 5-year plan of what is worth doing, a prioritization system. Right now, it is like putting everything together and calling it the National Health Growth Strategy. And this is an example of things that have been around for 2 or 3 years, but now are included in the strategic plan. So we just recently publicized a draft version of this National Genomic Medicine Strategy, and it is now made public. Part of this business is that since these issues come so much under your skin, everybody has something to say, has an opinion. Preparing strategies like this, it has to be very transparent, it has to be very open. That also supports and guarantees the political acceptance of these kind of documents when they are finalized and submitted to political decision-making in the ministry. And I want to emphasize that genomic medicine has to be in the service of public health. And this is also one of the main topics that Italy introduced to the health discussion of the EU during its presidency, and I have been informed that Luxembourg, who will be the chair after Latvia, is also going to continue along these lines. We tend to think that personalized medicine, which is one of the hot topics of research and development in health right now, is just about molecules, but that's not true. Personalization, innovation, has very much to do with information management, handling, e-health, mobile health, and so on. And in a country that lost its Nokia prestige, it is quite understandable that there is plenty of skillful workforce, academic, developmental, innovation people. So there is a whole lot actually going on the ruins of Nokia in this field in Finland. I'm not saying that this is materialized, it has materialized yet, and there is a major difference between the uptake of new technology from the pipeline of new medicines and the pipeline of new e-health applications. And at some point there is going to be a confrontation. So what is the degree of evidence that needs to be provided before we adopt into the public healthcare, the publicly funded healthcare system, the fruits of all this developmental work? Is the threshold lower than it is for medicines? It has to be, but how much evidence and proof we must ask? It cannot be just an open gate. The Ministry of Social Affairs and Health has attempted to put some order in the e-health and mobile health world through publicizing a new strategy on health information management. And unfortunately, this is the only English slide that they can provide for the time being, but this is a brave attempt somehow to get some concerted action also in the e-health and mobile health part of the health growth strategy, among other goals that this strategy actually has. This slide reminds me of always us being upon surveillance by the public. E-health and e-health is actually the one that everybody now can yell at and say that it is just a disaster in the country, although objectively it is not perhaps true. And when we introduce the concept of personalized medicine, be it cancer care, be it genetic medicine, be it whatsoever, we better prepare well our information strategy. We make it very transparent, very understandable to people. Otherwise, we will fail. Not to repeat what happened with the first era e-health applications. In the beginning, I mentioned that we need some low-hanging fruits, some evidence that innovation, development inside the health system, and then bringing back the results applied to all providers in the country is actually worthwhile. That concept actually works. Doesn't only benefit some companies who take their profits from whatever was developed in the health system. So I took a couple of examples here in the end of my presentation to show also the versatility of the growth strategy. First, an application that brings together molecules and e-health and bits. One of the major problems in patient health is medication safety. And if we one day can bring together all the single elements that we know that are needed to improve medication safety and also efficacy, They are all there, but they are not connected. So this is one of the challenges, and if we can manage to show that by new innovations and new approaches to this problem, we actually can reduce medication errors, we have succeeded. And it also has a major impact on waste in healthcare. Another totally different example is this one. This is an e-health or e-management application. We have a plan now supported by the Ministry of Finance to develop a common electronic governance system, which also means common operations between what we call the security sectors. Police is about 40%, emergency care is about 40%, and the rest is divided between different other authorities. They are going to have a single common operational system and also operational centers to respond to crises among society. And I think that this is one of the major tests also between ministries. Ministry of Internal Affairs now comes into play also. That will show that the government actually, when it asks for concerted action from the municipal authorities, is developing a counterpart on the governmental side. So I have touched different types of activities where the Ministry of Social Affairs and Health is now involved. The problem is that they are so versatile and they are so different from what we used to work with, mainly legislation, that it is also a challenge for our internal organization so that we can respond to questions that other ministries, the private sector, the public, the municipalities make to us about what does this all mean? And how are you going to govern this? And our hope is that the next government in its program will have a more steady basis, will give us some resources to have a more steady basis for the cooperation between different ministries, so that all these fine plans, ideas, understanding what should be done will be done. And we will have a small core facility to manage all this. Madam Chair, I'm saying a few personal comments in the end of my presentation. I have mostly shown things that the ministry is working with. But as a healthcare personnel and previous doctor and also research educator for young MDs, PhDs, I have a few words to add. It's very difficult to prove this, but I think that if you think about the vitality of our workforce, its ability to question traditions, follow whatever is found out in the world, because it is a global field, be innovative themselves, be active participators in the constantly changing world. I think they need an active understanding of research world. That means they have to, at some point of their training, be part of a research group to understand that it's not easy to get new information. Therefore, I think that strict separation of research, innovation, and care, be it preventive, curative, palliative, is detrimental. Since at the same time, the financial sector asks for lean processes and very strict use of money, use of time, we have to protect our medical and nursing and health professionals so that in their everyday lives they won't be worn out, but they maintain some creativity that is necessary for us in the future. Thank you, Madam Chair.
Now it's turn for questions. I'm just handing over the microphone here.
Jaakko, University of Thought and IT background. So in the medical system, I understand that you need to have some means to have better decision support at every level, right? If somebody comes up with some medical rule, it has to be implemented in the IT. You always have to assess whether these rules hold on the entire system. You need to do research. So how do you plan to solve the question of bringing together in the linkable form all the different data sources so that this kind of research can be actually done?
Thank you for the question. That was the one slide that I omitted. Well, you know that Finland has made a fundamentally different decision from most of the other countries when it comes to patient charts and health information. It's the Kanta archive concept that all healthcare providers, public and private, have the obligation to store every bit of data that is created in the care process, and also some managerial data in a single national archive in a structured form. Most of that information should be in a structured form, step by step. Now the problem is that when this legislation came into act, it was considered an archive. And now we have to lift that ban, so to say, so that all that data would be available real time for structured analysis, for data mining, for whatsoever, so that would serve managers and planners on all levels of the health system, from a single point of care to the national planning. This is a major effort. It will take a few years. We also have some national registries where data is now put aside before it is archived in Kanta. This is not viable, but we have to put everything together, and we have to make it possible for these different registries to combine data. For the time being, there are legal barriers that you cannot combine personal data from different registries, which makes a comprehensive view and management impossible. Now, if I understand you correctly, then if you introduce an intervention, you should be able to predetermine what are the data time points and data sets that are relevant and valid for the evaluation of that new intervention. That is exactly what we should do, and we are very clumsy in that yet. And also, if you have a proof from a research setting, and then you put that into real-life test, the results can be totally different, and that's why we always need this, what in traditionally is called the phase 4 surveillance programs. They have to be much more relevant and comprehensive. Then this, which I very briefly touched in the beginning, the introduction of big data or data that is provided by the patients and citizens themselves. There is a plan that there will be a common pathway, national pathway, for those who are willing to include personal data created by themselves into this Kanta archive, so that with a patient's permission, also that information would be available for analysis and use by the clinicians who are responsible for the patient's treatment. If I'm very honest and straightforward, one of the drivers of these activities, and I'm sure Arno Palotie will talk more about this, is that people do acquire genomic data themselves today. And question is that irrelevant? Are we interested? Can we make use of it? And how do we pursue quality control?
But you can link data.
Well, we have now realized that we must. But as I told you, there are, for the most legal obstacles right now, and there is actually a new legislation project initiated last week that examines what regulations must be lifted so that all data can be put together and handle safety. because this is sensitive personal information.
Thank you. Some more questions? Fine.
You have ambitious plans.
Yes, we do. We know.
So, which stakeholders are most difficult to convince to kind of join this joint approach? If you can pick them out, or if not the most important, then what are kind of the challenges by different stakeholders? So, what are their concerns?
That is a very intelligent question. I didn't speak too much about Team Health Finland concept, which is managed by the Ministry of Industry and Economics. I would say that the industry representatives, they are impatient. They think that the public sector is sluggish. They push us, and I also omitted a slide where I showed the timescale of when we wrote the health growth strategy. There are very strict time points, and I compared it with the pace of our legislative preparation and parliamentary actions and all of it. It takes 3 times the same time. That is an obstacle because we are used to different cultures, operational cultures. Obstacles. I think the greatest obstacle is ignorance. Not understanding what's going on. That the world is going, it passes us from the left and the right-hand side. The healthcare system is a traditional cultural organization. It's very conservative. But I would say that now we have a critical mass of people inside the system. And I'm happy to say that also among the top managers who really see that this is a paradigm change that's there. We better adapt, we better make use of it. But the average clinician, I'm not so sure. So it's an educational challenge, and our medical societies, for example, Duodecim is very keen on developing programs, for example, educational programs on genomic medicine to students, but also those who have practiced medicine for 20, 40 years. Because they have to be re-educated, or we have to be re-educated, me included. Oh, you asked something. May I add one thing? Yeah. Very honest with you. Some of our legal experts, because this protection of individual data, sensitive information, all the history that Europe has in application of genomics as it was understood in those days, all these obstacles are there. And there's no other way but open discussion. And also some ethical experts have made tough questions. But perhaps our most important ethical authority, Professor Veikko Launis, has totally changed his wording and is now preaching the right and responsibility of the population to benefit from everything that I described in my presentation. Also the obligation of individual for the society to be involved.
Thank you. Any other questions? If not, then let me thank you for the excellent contribution to our event, and I think it shed a very good light to what you are doing and focusing in Finland, but also kind of extended the comment which was made by Professor Vasar that the most difficult times in terms of this strategy for the Ministry of Social Affairs are still ahead.
Yes. And if I may add one thing that when I discussed with you last night this strategy, which I unfortunately couldn't understand much of, please translate it into English, and we have translated our health growth strategy in English, but not all the material. I think that there is a good reason for the two countries to cooperate and learn from each other. Some of the ideas I heard from you are such things that we haven't really come to think about. That was the reason why I had to make a totally new presentation for this event, and I think that there is a win-win situation arising.
Thank you very much. nii, aga siinkohal tõmbame ennelõunase otsad kokku ja nagu Iivi enne mainis ka, et strateegia nii-öelda tegemise vastutus hakkab akadeemial ajaliselt nii-öelda lõppema jaanuari lõpuga ja seetõttu on selline veel kommentaaride ja tagasiside tegemine natukene ajaliselt piiratud, mis tähendab tõesti, et kui strateegia juhtorganid ja ekspertkogu kogunevad 26. jaanuaril, siis hea oleks tõesti selleks ajaks saada teilt veel nii palju põhimõttelisi ettepanekuid, kui neid kas dokumenti lugedes või siinkohal saalis olles tekkinud on. Ja siis jaanuarist edasi juba tõesti, nagu Iivi ütles, et kontaktandmed vahetuvad ja sellest kindlasti anname teile siis eraldi ka teada. Aga sinnamaani võib saata kommentaare või otse minuga suhelda sellel meiliaadressil, mis on ka selle dokumendi päisesse pandud. Aga nüüd avanevad need uksed ja seal uste taga on lõunasöök. Ja peale lõunat koguneme siia siis tagasi, et personaalmeditsiini tervishoius rakendamist arutada.